I will consider that all of us here knows the definitions because I only have 15 minutes, so I will try to be a bit quick. So let's move on now to the literature review. One of the reasons why I have chosen to talk about this topic is that actually you can see in the literature review that this topic is a bit controversial. So some studies are with immediate implantation in infected sites, and some other authors are against. In red, you can see the studies that are against, and their arguments are, for example, immediate implantation in infected sites compromises osseointegration. There is a tendency towards more and more failure and a significant increase in peri-implantitis. And the studies or the authors that are with says demonstrated that there is no statistically significant difference between infected or non-infected sites, and also that these kind of approaches are predictable if done correctly. So as you can see from here, it is somehow a topic that is controversial, and it's interesting from here to see the guidelines. You can see that the guidelines are not really, there is no gold standard approach or guidelines towards immediate implantation in infected sites. For example, the American Academy of Periodontology and the European Federation of Periodontology do not have any kind of recommendations or whatsoever. The European Association for Osseointegration is against in acute infection, so it is against, and the ITI said that it is with if there is a chronic periapical infection. However, they didn't mention anything about periapical granulomas, about periodontal abscesses. So what about them? Can we do immediate implantation in periodontal abscess or we cannot? So maybe the first conclusion of this lecture is that until today, there is a lack of gold standard protocol for immediate implantation in infected sites. This is very important. Now, clinical studies are indeed important. The guidelines are important, but I think this is not enough. And when it comes to immediate implantation in infected sites, if we really want to understand what's happening, we have to see histological studies, because histological studies will give us more an idea, will give us actually the idea about BIC, bone to implant contact, about the nature of this osseointegration, the quality of this osseointegration. So let's move quickly to what I think is the most accurate, or what is the most insightful, what is the most interesting in this lecture. When it comes of immediate implantation in infected sites, we have to see histologically what happens. So I will share with you a histological study done by Shang et al. In the study, they have compared 3 sites on dogs, of course, histologically. After 3 months, they did the histological study. One site is a control group, so there is no infection. The other side is a an experimental group, so there is an infection without membrane, and the third group is an experimental group, so there is an infection with PTFE membrane. After 3 months, they did the histological studies, and they revealed a very important thing to know, that when you do immediate implantation in infected sites, there is a significant decrease in BIC, in bone to implant contact. So the percentage of BIC decreases significantly compared to healthy sites, the sites that are with no infection. These findings were confirmed in other studies, such as a study by Novaes et al. Also, you can see that when we have infection, the BIC, the percentage of BIC decreases significantly compared to control groups. So we can conclude from here that there is a significant decrease in BIC in infected sites, and this is a very important thing to know and to understand. So maybe this is the second conclusion of my presentation, of my lecture. So far, we have understood that BIC will be affected negatively. There is a decrease in BIC. And from clinical studies, we've seen that there is until today no gold standard approaches, and that some authors are against immediate implantation in infected sites, and other authors are with immediate implantation in infected sites. So the question here is, do we perform or not immediate implantation? That's the question. And in this lecture, I've decided that we want to perform immediate implantation in affected sites, but we want to advocate or suggest an optimal approach. Now, of course, here I am not suggesting that I'm going to give guidelines, but what I'm going to do is try to find and to suggest, and this is the main aim of my lecture today, try to suggest an optimal approach that we can always follow when we want to do immediate implantation in infected sites. The first step is to divide this approach, to divide this optimal approach into 5 factors. The first factor will be implant selection, and in implant selection, I will choose any ridge or a blue diamond from Megagen. So let's see why this implant selection is very important. First of all, because of the morphology of this implant, the knife threads, according to many studies, knife threads increases the BIC, so increases bone to implant contact, and this is key. This is what we really want to compensate the decrease of BIC that we obtained because we are because we are placing implants in infected sites. Secondly, this X-speed treated surface, so also based on many studies, there is an ion calcium rich composition that will accelerate the mineralization on these surfaces, so we will have a greater creation of hydroxyapatite. Also, we are compensating from the low BIC that we saw in infected sites. And the third very important thing is, and I will suggest in order to optimize our approach, to use plasma X speed motion, also based on a study, for example, a recent study by Makari et al. It was actually an histological study done on humans after 4 weeks. They've confirmed, they've demonstrated that we can have a significantly more important BIC if we use the X speed, the plasma X motion. So if we have an X speed active, you can see that the mean value of BIC was statistically significantly higher when we use the X speed active. So back to my 5 factors that will increase our approach in immediate implantation in affected sites. Implant selection, use any ridge or blue diamond because of the characteristics, and try to use the plasma X speed active. Because we have only 15 minutes, I will be a bit faster for the other parameters. So do prophylactic antibiotics, give antibiotics prophylactically for these patients, and this is based on studies, of course. Do a very thorough and precise mechanical debridement, and we have to try to control as much as possible the patient-related factors. And we can remember here my first lecture about the importance of supportive peri-implant care and about the importance of not day 0 only, but the stability, the long-term stability after placing an implant. And finally, I will suggest to enhance the chemical disinfection, so to use other approaches after mechanical debridement. So after, as an additional tool after mechanical debridement, to use local disinfection solutions such as photoactivated disinfection, also known as photodynamic therapy. So here I will base what I'm going to say on a study that I've recently published. This study was made on periodontal pockets. In these periodontal pockets, we have demonstrated that the use of a specific protocol made of known as photodynamic therapy, and made specifically with a photosensitizer and a light source. So I will briefly define photoactivated disinfection. It is the use of a photosensitizer. This photosensitizer is a molecule that will go and fix specifically on certain bacteria that we actually want to kill. And then with a light source, we can activate this photosensitizer, and this will result in a strong release of reactive oxygen species. So since we are dealing with infected sites, it is, of course, very important to try as much as possible to increase the local disinfection. This will kill more bacteria. We will have a stronger bactericidal effect. Therefore, we will have better results. So very briefly, the rationality of photoactivated disinfection is that mechanical debridement is limited to what only we can touch, what only we can remove. So with photoactivated disinfection, we will have a deeper penetration, so a better bactericidal effect. Also, our study have demonstrated that this particular protocol, of course, the protocol has to be studied, what photosensitizer we have to use with what light source. According to our study, we have demonstrated that this protocol can significantly decrease not only the total bacterial count, but the bacteria significantly decrease the count of the bacteria that are directly linked to peri-implantitis and periodontitis, such as Porphyromonas gingivalis, Treponema denticola. We did a real-time PCR test for specifically these bacteria, and we found this protocol to be effective on them. So, therefore, let's see, this is the protocol. These are the irradiation parameters. As I've said, these parameters were calculated. Today, unfortunately, we don't have time to explain in details why we have chosen these parameters. And also, the protocol is basically to apply the photosensitizer inside the socket to remove the excess of the photosensitizer that will extend, wait almost 1.5 minutes, because we want to have a deep penetration of the photosensitizer, and then activate the photosensitizer with the laser with a dedicated special tip that will this will result in a release of reactive oxygen species. So back to my suggested optimal approach to deal with infected sites: use specific implants, give antibiotics, very thorough and precise and good mechanical debridement, use photoactivated disinfection to increase disinfection, local disinfection, and try as much as possible to control by explaining the importance for the patient-related factors, oral hygiene, etc. So with everything that we have said, finally, we can talk about this case that will summarize, will conclude everything that we have just discussed. This patient is otherwise healthy. He is a smoker. We can say that he is a heavy smoker. His chief complaint was discomfort and he wanted rehabilitation. This is an infected site, so I've decided to treat this patient exactly as we've suggested using this optimal approach that we have just talked about. First of all, give prophylactic antibiotics. Then we have to do an extraction, a traumatic extraction for sure. Use specific implants, so the choice of the implant. In this case, I've chosen any ridge because of the characteristics and the advantages of the morphology of the treatment of the surface. If possible, use plasma X. Then irrigate the socket with toluene chloride, wait for 1.5 minutes, activate toluene chloride with the photoactivated disinfection tip, so with the 635 nanometer diode laser, and then place the implant. These are the results immediately after treatment, and this is only after 2 months of the treatment. Now the patient will go to the prosthodontist who will do 2 ceramic crowns. So takeaway message for my presentation: first of all, until today, there is no standard approach for immediate implantation in infected sites, and this is why I believe this presentation is very important. Secondly, the BIC significantly decreases in infected sites, so we need to compensate with knife threads, X-speed surface, plasma X. These are key factors in augmenting BIC. And finally, photoactivated disinfection enhances significantly the local disinfection, so it is always a good idea to use it in order to have an optimal management of the infected sites. So thank you very much, and I'm ready for the questions.